Today's topic is going to be on balanitis. Now, balanitis means we have inflammation of the glans penis. A couple of other quick definitions before we jump into this topic. Posthitis means we have inflammation of the prepuce, and balanoprostitis means we have inflammation of the glans and of the prepuce. Now, posthitis and balanoprostitis is only going to be seen in uncircumcised males. Balanitis can be seen in both uncircumcised and in circumcised males. For the most part, in clinical practice, everything is kind of clumped together into the term balanitis, which means we have inflammation of the glands and of the foreskin. Now, we have to keep in mind and we have to remember the normal physiology of the child. If the child is uncircumcised, it's very normal to have a physiological phimosis. Phimosis means that we can't retract the foreskin back over the glands. This is normal. We have adhesions that attach the foreskin to the glands early in life. For the most part, this is going to separate naturally by 11 years of age. However, it's still considered normal to have this attachment by 17 years of age. And so long as the patient can urinate properly, we don't need to do anything about this whatsoever. Now, moving on to the etiology of balanitis. Now, the inflammation can either be due to infectious causes or non-infectious causes. The infectious causes are really going to include anaerobic infection, candida, gonorrhea, herpes simplex virus, which is considered rare, HPV, again, is considered rare, and finally, strep infection. The strep infection can be group A and it can be group B. The non-infectious causes here are going to include allergy, contact dermatitis, atopic dermatitis, psoriasis, drug eruptions, and poor hygiene. All right, moving on to the specific etiologies one by one. Now, candida infection, this is going to be most common in males who have a female partner with recurrent infection. It can also be seen in children, especially if there's recent antibiotic use or if we have contact dermatitis. Now, in children, really the most common cause here is going to be poor hygiene. Now, when talking about bacteria, most common etiologies here are going to be E. coli, enterococci, staph infection, and strep infections. Like we said, the strep infection can either be group A or it can be group B. Now, contact dermatitis and allergy. Not only can balanitis be due to poor hygiene, which means we don't have the proper cleaning technique, but it can also be due to excessive cleaning. So this excessive cleaning with water and soap is going to irritate and it's going to over dry the glands, which can ultimately lead to balanitis. Drug eruptions can also occur. Now, drug eruptions, for the most part, are going to occur a few hours, or 30 minutes, I should say, to a few hours after ingesting the medication. Common medications here that are implicated are going to be tetracyclines, salicylates, and sedative hypnotics. And really, balanitis can be the sole manifestation of a drug eruption. Now, one last thing regarding candida infection. Candida infection that results in balanitis can really be the initial presentation of diabetes, especially in an otherwise healthy male. So if we have balanitis and this has never occurred before, or if we have recurrent balanitis, it's probably a good idea to do a quick glucose check to rule out diabetes. So those are the etiologies here. Let's get into the signs and symptoms of balanitis. All right, moving on to the symptoms of balanitis. Now, for the most part, patients are going to present with a rash, which are going to be present as erythematous papules, which can either ulcerate or scale. Patients are going to have pruritus, pain, and tenderness as well. Now, really, if this is left untreated, then this can eventually lead to adhesions, edema, which can ultimately lead to phimosis and or paraphimosis. And paraphimosis is really going to be a urologic emergency. Paraphimosis means we have the foreskin that's retracted behind the glands, causing a tourniquet effect. Now, regarding the paraphimosis, there are times where paraphimosis can actually be mistaken for balanitis. Like we said, balanitis presents with erythema, rash. Paraphimosis can also present with a red glands, and this is because of the constricting effect that occurs with the foreskin constricting behind the glands. What happens is this tourniquet effect is going to reduce venous outflow, but it's still going to allow for arterial inflow, which creates this erythematous glands. So don't mistake paraphimosis with balanitis. All right, so now there are going to be some possible indicators towards the etiology of Balanitis. If we have strep infection anywhere else on the body, skin or throat, then this is a possible clue to having strep as an etiology for Balanitis. Foul-smelling discharge might clue you into having anaerobic infection. Satellite lesions are going to be present with candidal infection. And if we have discharge or ulcerations of any kind, we have to do an STD workup, especially for chlamydia and gonorrhea. Finally, when doing the physical exam, if we palpate the suprapubic area and we have tenderness to palpation there, this is where the bladder resides, and this might be an indication of a complicated Balanitis, which means we have urinary retention, and these patients ultimately need to be catheterized immediately. Moving on to the diagnosis of Balanitis. Now, the very first thing that we have to do is exclude the possibility of paraphimosis. Like we said, this is a urological emergency, and we really don't want to miss this diagnosis. Now, once we've excluded that possibility, the next step is to really do a history and a physical, and we can really diagnose contact dermatitis, poor hygiene, and candida infection on clinical grounds. These are fairly easy to diagnose, and go ahead and start the patient on treatment as appropriate. For those cases that are not quite so clear, then we probably want to do some type of laboratory testing. Things are going to include glucose screening to make sure we don't have diabetes, microscopy, and we're going to want to do a chlamydia and gonorrhea screening on certain patients as well. Bacterial cultures really add little to the diagnosis, but like we said, if you're uncertain of the etiology, go ahead and get a bacterial culture. Also consider getting a group A strep culture. Like we said, strep is a possible etiology. Strep can be transmitted orally through oral sex, so we have to make sure that that's not the reason the patient is presenting with Balanitis. Also be on the lookout for inverse psoriasis. Inverse psoriasis presents a little bit differently than the classic presentation of psoriasis. This is going to be noted in the intertriginous areas, and it's not going to have the scaling or the silver plaques that are going to be normally associated with classic psoriasis, so inverse psoriasis. Also, scabies, HPV, these types of infections are also going to present with papules, and it's also going to present with Balanitis-like symptoms. Lastly, we want to look for lichen planus. Now, lichen planus can present on the genital area, and it's going to present with volaceous papules that are present over the glands. So these are different possible etiologies that might resemble Balanitis, these last few things here. We want to exclude these as the possible differential diagnosis. Moving on to the treatment of Balanitis. Now, to really reduce the symptoms that are associated with this, we're going to want to have the patient do sitz baths, and we're going to want to have them perform proper hygiene. They should really get a Q-tip, pull the foreskin back, and make sure that they're cleaning properly. Water irrigation, especially at the beginning, is also going to be very important here. Now, if we have improper hygiene as a diagnosis, then we continue doing these things. We also have to educate the patient on how to prevent this in the future. If they're not properly cleaning, then we have sweat, we have exfoliated skin, debris, bacterial organisms that are naturally produced on the floor there are going to overproduce, and it's going to lead to a recurrence. So proper hygiene is very important. We also want to educate the patient not to over-clean with water and over-clean with soap. Like we said, this can lead to atopic dermatitis. This can cause irritation and over-drying of the skin, which ultimately leads to Balanitis. If we have candidal infection, we're going to treat with topical azoles, clotrimazole or miconazole. We're going to do this for 1 to 3 weeks, and we can also use fluconazole 150 milligrams as a single dose, or nystatin as alternative therapy. But really, first line here is going to be clotrimazole or miconazole for 1 to 3 weeks. Now, if we have dermatitis or allergy as the possible etiology, then we're obviously going to want to remove the offending agent, and then you can also treat with hydrocortisone 1% cream. Now, I know a lot of people are scared of treating with a steroid, especially in this area, because it's supposed to be contraindicated, but it's fine. Cream is going to be less potent than ointments, and 1% is going to be a very low dose. Hydrocortisone is a very weak topical steroid. So you can really treat with hydrocortisone 1%, cream twice daily, but no more than 1 week. This is considered safe, and this is going to help with resolution of symptoms. If we have a drug eruption, then again, this is going to be self-limiting. This is going to resolve on its own as soon as you stop the medication. But if the patient has severe symptoms, again, hydrocortisone 1% cream twice a day for no more than 1 week can be given. If you're considering anaerobic infection, then we're going to treat with the appropriate antibiotics. Options here are going to include metronidazole 500 milligrams twice a day for 1 week. We can do augmentin, which is going to be 875 over 125 twice a day for about 7 to 10 days as well. We can also use clindamycin cream applied twice daily. Again, this is going to be for 1 week duration. If we're thinking group A strep, then this is going to be treated exactly like we would treat any other type of group strep infection. We're going to choose penicillin. We're going to do this for 10 days. If we have a penicillin allergy, then we can substitute with cephalosporin, macrolide, or clindamycin. Again, this is going to be treated no differently than any other type of group A strep infection. Now, if there's no improvement after 4 to 6 weeks of treatment, this is indication to refer to your urologist for the appropriate workup and the appropriate treatment. Now, one word of caution, circling back to the issue of phimosis, if you try and resolve the phimosis by simply pulling the foreskin back over the glands, you can precipitate paraphimosis. This is a urological emergency. If this happens in the office, you have to refer to the ER immediately. So if you don't have the appropriate knowledge or tools to treat the phimosis, I would suggest not pulling the foreskin back over the glands. Like we said, this can precipitate paraphimosis. All right, so that concludes today's lecture on balanitis. Take care, and I'll see you on the next lecture.